Good afternoon, everybody. First of all, I would like to thank Professor Kochis for his kind invitation to this really interesting congress. My topic is COVID-19 and lung cancer. I have no conflict of interest to declare for this presentation. And I would like to stay for my presentation on two issues. The first one is about the outcome of COVID-19 in patients with, among patients with lung cancer, about severity, if they have much higher morbidity or mortality, and about the effect of anti-cancer treatment, because this is a treatment that lowers the ability to fight COVID-19. And the other issue is a general issue that this pandemic impacts our everyday practice and management of all diseases. And as this, there was a new strategy about management of patients with lung cancer, about the delay in diagnosis, the delays in screening. There were many changes in treatment schedules, follow-up visits, and also there was a decrease in enrollment in many international clinical trials. Some basic information about history of COVID-19. In December 2019, a pneumonia cluster of unknown etiology appeared in the city of Wuhan, China. About 4 months later, on the 11th of March 2020, WHO declared COVID-19 disease as a pandemic, and up to date, there are more than 500 million cases, about a half billion cases of COVID-19 patients, and they are about 6.2 million deaths attributed to the disease. These data are from about 2 days before. Some general information about lung cancer and COVID-19. Patients with lung cancer and those with hematological malignancies appear to be at highest risk of death from COVID-19 disease, and especially hematological patients with hematological malignancies has the highest mortality rates among all oncological patients. There is a significant interplay of factors frequently associated with lung cancer, like smoking-related lung damage. There is many data that smoking is an independent risk factor for the severity of the disease. Also, patients with lung cancer also have important comorbidities like cardiovascular and respiratory diseases, and these comorbidities are also independent risk factors for COVID-19 disease. Older age, the mean age of patients with lung cancer is about 45-year-old. And also in the microenvironment of the lung parenchyma, there is a defective pulmonary and alveolar architecture due to previous thoracic surgery or radiotherapy, or due to atelectasis, for example. From many studies, There are some conclusions that patients coming to the emergency department who are COVID positive and also they suffer from cancer, usually they are older compared to the general population. They are harboring more than 2 comorbidities. They are more frequently have a severe disease, and many times they present with respiratory failure. They had higher rates of hospitalization. There are some data I will show later. About 60 to 70% of patients with lung cancer, they are admitted to hospital after COVID-19 disease, and all these interactions put lung cancer patients in an extremely risk group for COVID-19 illness. This is the first systematic review about lung cancer patients in the retrospective cohort studies from COVID-19 disease. You can see here the first study comes from China. You see from about 13,000 patients, 23 of them had lung cancer. It is estimated that from the total patients with COVID-19, about 1 to 8% of them suffer from cancer. So you can see here all these studies, retrospective or observational studies, and the last one is a specific study, is a multi-center study about patients with thoracic malignancies, not only lung cancer, but also mesothelioma and a small number of patients with thymoma. And you see, this is the first publication about 1,000 patients with thoracic malignancy, and you see how high is the mortality rate. The mortality rate is about 4 to 5 times higher than the general population. You see, it's about 25 to 40% in some cases, and the hospitalization rate is about 60 to 70%. So it's a very risk group, all these patients with lung cancer. If we put all these numbers together, you see that the hospitalization rate is about 60 to 70%. Need for mechanical ventilation, 20 to 25%. Admission to intensive care unit, 12 to 20%, even though a lot of, in this large study, in this teravolt study, the authors state that about only 10% of those who completed the criteria for admission to the intensive care unit were finally entered the intensive care unit. So only a small number of patients with lung cancer finally admitted to the intensive care unit. And the mortality rate is about 25 to 40%. It's very high. This is the first publication, the first 200 patients from the teravolt study. You see the numbers, the mortality rate, the hospitalization rate. Only 10% of those who met criteria for intensive care unit were admitted finally to this department. And this is the last publication from this study, the TerraVolt study, about 1 year after the beginning of the trial. You can see here that about 1,500 patients from 18 countries, about 60% of them were from Europe, were included in the analysis, with a mean observation period of 42 days after the diagnosis of COVID-19, and fatality rate was finally 24.2%. And this trial also had the aim to find a prognostic model about the important risk factors that were related with mortality rate. And they found something quite near everyday clinical practice, that if a patient has two diseases, then the prognostic factors come from both of them. So if the patient is older, the performance status is lower. The stage of the lung cancer at the time of the diagnosis of COVID-19. If the neutrophils are higher than the upper limit of normal, the procalcitonin is higher from the upper limit of normal, CRP, and if there is a pneumonia on CT or on X-ray, these are independent prognostic factors for these patients. They also, in this study, this is an important Sankey diagram. It's a very easy to use nomogram. So if you have a patient who has a good performance status with a normal CRP and no pneumonia on chest X-ray, then the fatality rate is only 8%. On the other hand, if you have a patient with a very low performance status, for example, 3 or 4, if the patient during COVID at the admission to the hospital has high neutrophil count and the stage of the lung cancer is 4, then the fatality rate is approximately 65%. So using this nomogram, you can see what you expect for a specific patient with lung cancer and COVID-19 disease. What about lung cancer treatment and the outcome of COVID-19? In an updated analysis of the 1,000 patients approximately, which was presented at ESMO, patients receiving chemotherapy alone or not receiving treatment had worse outcomes compared with patients receiving immunotherapy, chemoimmunotherapy, or targeted therapy. This analysis is not very specific because it compares chemotherapy on the one hand, but on the other hand, we have patients who take chemoimmunotherapy. In other trials, it showed that they showed that chemotherapy was not associated with a worse outcome. And in other trials, they showed that immunotherapy is also a treatment that were related with better outcomes. And also targeted therapy, Spyratos therapy, was not associated with higher mortality rates. So it's not very clear if chemotherapy is related with worse outcome in patients with lung cancer and COVID-19. On the other hand, for patients who undergo surgery for lung cancer and they were infected after surgery or in the perioperative period with COVID-19, then the mortality rate is quite high, is much higher than patients with lung cancer and COVID only. It's 40 to 50% compared with 25 to 40%, which I show you previously. What about vaccination and the immunity of patients with cancer in general? This is a quite large study, the CAPTURE study, with more than 500 patients, all with cancer, various types of cancer. And they showed that from patients with hematological malignancies, only about 60% of them make seroconversion after 2 doses of the vaccine. About patients with solid malignancy as a whole, they showed that about 80 to 85% of them had a seroconversion to protective levels of antibodies, neutralizing antibodies. You can see here, these dots are for patients who had no previous infection, and this with this arrow is patients with a previous infection. You can see here for the wild type and for the other variants, the alpha covariant, beta and delta. You can see here for, with the dots for patients with solid malignancies that at the end you see here that the dot comes up, but here in patients with hematological malignancy, the dot is quite near the zero axis. So in patients with hematological malignancies, vaccination is not so effective as in patients with solid malignancies. So on the other part of my presentation, what is the impact of COVID-19 pandemic on lung cancer management? I will show some data. This is some data from the United States. You can see here about cancer screening. There was an important decrease in cancer screening for colorectal cancer and breast cancer. The prostate screening was quite stable between 2019 before pandemic and the first year of pandemic, 2020. And you can see here the diagnosis about lung cancer. The diagnosis were quite stable. Even in 2021, the diagnoses were quite increased. So we can state that in the United States, there was no decrease in diagnosis of lung cancer during the pandemic. But for other cancers, also the data are quite similar. Even for prostate, there is an increase in the diagnosis. What about lung cancer screening? In the United States, lung cancer screening with low-dose CT is an official indication and it is covered by insurance companies like Medicare. Even though the rates are quite low, even though there was no decrease in screening. You can see here that 6.6% was for the year before pandemic, 2019, and 2020, the first year of pandemic, the percentage of for lung screening was 6.5%. You can see here the states, and this is the difference, the ratio between before and after the start of pandemic. You can see in some states there was a decrease, in other states there was an increase in the rates of screening. So it's quite stable for these years, 2019 and 2020, lung cancer screening. What about cancer deaths for the top 5 cancers in the United States? The numbers are quite stable. Only for lung cancer there was a decrease in mortality rates. This is mainly due to the introduction of immunotherapy and chemoimmunotherapy as a first-line treatment for patients with lung cancer stage 4. So I believe that there was no important impact of COVID-19 illness on lung cancer mortality, as taking into account lung cancer as the cause of death. And what about clinical trials and COVID-19 disease? You can see here during the first part of the pandemic, this is with the blue line is before the pandemic, and the red line during the first year of the pandemic. You can see here for the first 8 months there was a steady and important, statistically important decrease in the enrollment of clinical trials for lung cancer. But after September of 2020, there was a steady and comparable condition to the previous year. So after September of 2020, clinical trials, enrollment rate of clinical trials was quite similar to the year before the pandemic. So only for the first 8 months, there was an important decrease. You can see here the comparisons. What about challenges the investigators and the doctors and patients have to deal with? Most centers state that there were fewer eligible patients to enroll in clinical trials. There were patients were not so willing to visit the site. There was a difficulty with complying with the protocols, and the sponsor of the clinical trial sometimes hold it or for a few months or for a year, for example. And there was, to deal with these challenges, there were new strategies in everyday clinical practice, but also for clinical trials. There were modified monitor requirements. There was telehealth, a lot of phone visits or visits via internet. Labs allowed it to do for patients elsewhere out of the hospital to independent labs, and also many companies and clinical trials tried to mail oral medications to their patients. There are some algorithms quite simple to sometimes to differentiate the symptoms between lung cancer and COVID-19 illness. If the cough, breathlessness, fatigue are quite persistent, unexplained, or the duration of the symptoms are more than 4 or 6 weeks, then you have to have an X-ray or a CT scan and to deal with a possible lung cancer. If there is an acute onset and the symptoms are not persistent, then you have to think about COVID-19 disease. And if there are red flag symptoms like hemoptysis, chest pain, weight loss, appetite loss, finger clubbing, neck nodes, thrombocytosis, in this case, if there are lung cancer risk factors, you have to think for this diagnosis. And very important, during the pandemic, you have to arrange for the examinations necessary for the patient, and before you have to perform a PCR before the patient comes to the hospital. And ESMO, like all other international association or societies for lung cancer, they provided new guidelines about management and treatment adaptations during the COVID-19 era. They divided patients and practices and what we have to do into 3 categories. High priority, there is an immediately life-threatening condition, and you have to do something on time. You have sometimes you are able to postpone your examination for 6 or 8 weeks for medium priority, and there are some low priorities in patients with a very good clinical condition and who are stable, who have, for example, who had a surgery 1 or 2 years before. You can see on the next slide some of these examples. If you have a new diagnosis of stage more than 2 invasive lung cancer with disease-related symptoms, and this is a high priority, a visit to administer treatment is a high priority. And for surgery, every cancer who is stage 2 or more, T2, N0, T3, T4, and N1, N2 disease. If the patient has a pleural effusion or pericardial effusion, is a high priority. On the other hand, if you have a new diagnosis of stage 1 lung cancer, you can postpone the surgery for about 2 months, for example. If there is a follow-up for patients with high risk of relapse, then you can postpone for 2 months. On the other hand, you can delay, for example, or you can delay for a ground glass nodule, which is a poor ground glass nodule. You can postpone it for all the pandemic or until the health system is quite stable to support a patient for his surgery, or a psychological support In this case, you can convert the follow-up visit to telemedicine. This is a diagnostic and treatment algorithm for patients with lung cancer who are suitable for surgical treatment. And you can see here for nodules more than 1 centimeters, you can wait for 2 months. You can postpone their diagnostic examination for 2 months in case the COVID-19 disease is quite high. And for other cases, for example, patients with a diagnosis of lung cancer, and if the stage of the disease is 2 or more, then this is a high priority. Also for other treatment, neoadjuvant or adjuvant chemotherapy is a high priority. On the other hand, adjuvant chemotherapy for patients with small cancers with no lymph nodes, or adjuvant therapy for the elderly or patients with comorbidity, maybe ESMO prefers to omit this adjuvant chemotherapy. Or in case of palliative radiotherapy or adjuvant post-operative radiotherapy for N2 disease, where the survival benefit is not very clear, or in case of prophylactic cranial irradiation in extensive stage small cell lung cancer, they probably recommend to replace by MRI active surveillance. Other strategies is to convert some treatment of immunotherapy instead of every 2 weeks, to increase the dose and give them every 4. For example, nivolumab, instead of 240 milligram, to give 480 milligram every 4 weeks, or pembrolizumab, to give them instead of every 3 weeks, to give it every 6 weeks. So in this case, it's you can reduce the number of visits. So the summary of this presentation is that lung cancer patients have been associated with an increased risk of COPD-19 infection, pulmonary complications, and worse survival outcomes compared to the general population. The world leading professional organization provided new recommendations how to manage and deal with patients with all cancers, and specifically for lung cancer patients. Telemedicine was preferred for non-urgent consultations, and a vaccine campaign was emerged as the main weapon to fight COVID-19 pandemic in patients in the general population and in patients with lung cancer. Thank you for your attention.